Hi everyone, this is Dr. Terri Messman Moore, and in this video I want to talk about the mental status examination. This is the second video in a two-part series focusing on the mental status examination. In a previous video we discussed certain aspects of the mental status exam. I'm not going to go over them again here, but I wanted to remind you that we generally start the MSC with an assessment of orientation and alertness. We also look at the appearance of our client, their speech, and mood and affect. As I mentioned before, mood and affect is a very substantial part of the MSC for most of our clients. In the second half of this mental status exam, we'll be focusing on thought process, thought content, and disturbances in perception. Thought process and thought content are different, and I want to take some time to clarify how they might be different. So when we think about the thought process, we're talking about how someone is thinking. When we think about thought content, we're talking about what they're talking about. Thought process and thought content can be affected in various diagnoses, and we often see incoherent thinking or disorganized thoughts that are related to what we call psychotic or thought disorders, such as schizophrenia, or in manic phases of bipolar disorder, as well as dementia and delirium. Thoughts also help us to estimate the level of intelligence and our cognitive capabilities of our clients. So when we talk about thought process, again, we're talking about how the thoughts are developing, how their thoughts are related to one another. Are the thoughts arranged according to a coherent topic? Are they appropriate answers to questions posed by the interviewer? Do they make sense? Are the thoughts logical? Can you even follow what they're trying to tell us? Are their thoughts coherent? When we talk about thought process, there's many different ways to label a dysfunctional or a problematic thought process. We tend to use the overarching label of disorganized when we talk about thought processes that are not logical, coherent, or easy to follow. Aspects of disorganized thought include looseness of association, flight of ideas, and ideas of reference. Looseness of association is the most mild aspect of disorganized thought. It encompasses two aspects of this looseness: tangential thinking and circumstantial thinking. So, circumstantial thinking is when someone gets off track from the topic of the interview, but they eventually answer your question. So their response is somewhat related to the question, but it isn't always addressing your question directly. Tangential thought occurs when the person's answer to a question is obliquely or in no way related to the question asked. This can be a sign of a significant psychotic process. Here's an example of a circumstantial response. The question is, do you have any children? The response: yes, I have two daughters. One is 18 and one is 24. Wow, you know what? You really look a lot like my 24-year-old. Did I ever tell you that when she was 4, I took her on a camping trip and she fell out of the canoe? Can you see in that example how the person made an effort to answer my question? However, they got sidetracked and started telling a story instead of staying focused. That's an example of circumstantial thought. Here's an example of tangential thinking. The interviewer asked the question, "Why are you here in the emergency room today?" The client's response: "There's a rat in my belly. He's gnawing on me. The rat is a lover. Are you a lover?" We can see in this example that the client, while trying to cooperate and responding to our question, it is very difficult to even understand what he's trying to convey. This type of thought process is usually indicative of some sort of psychotic process being present. Another aspect of disorganized thought is something called flight of ideas. Flight of ideas is a nearly continuous flow of accelerated speech with abrupt changes from topic to topic that are usually based on understandable associations, distractions, or a play on words. So flight of ideas may be seen during manic phases of the bipolar illness or in some types of schizophrenic disorders. Ideas of reference are actually a type of delusion where individuals may think that certain things around them have a specific meaning. We tend to see this around when individuals have paranoid schizophrenia, for example. So in other words, individuals might believe that the newscaster is giving them messages that are specific and special just for them versus understanding that the news is being broadcast to everyone. So ideas of reference are feeling that casual incidents and external events have a particular and unusual meaning that is specific to the person, to our client. So again, when we talk about thought process, we're trying to understand whether the thought process is coherent and appropriate. Coherence involves thinking in a comprehensible way so that they can convey their thoughts and feelings to us in a way that we can understand. Incoherent thinking is incomprehensible to others because words or phrases that our clients use are joined together without a logical or meaningful connection, and this can occur with clauses or between clauses. Next, we have thought content. Remember, thought content is what our patient is actually talking about. When we're looking for disturbances in thought content, we're trying to understand what our client is telling us versus how they are telling us. Significant disturbances in thought content pertain to delusions. Delusions are false beliefs that have no basis in reality, but yet are very firmly held onto. So a delusion is a false belief based on incorrect inference about external reality that is firmly sustained despite what almost everyone else believes and despite what constitutes incontrovertible and obvious proof and evidence to the contrary. There are several different types of delusions. Delusions can be bizarre, meaning that the content of the delusion is regarded as totally implausible by the majority of our culture. For example, being kidnapped and probed by aliens, or a man giving birth to a baby. Bizarre delusions can be a marker of some significant psychotic processes occurring. On the other hand, we have paranoid or persecutory delusions. In these delusions, the central theme is that one person or someone to whom one is close is being attacked, harassed, cheated, persecuted, or conspired against. I once had a client who came to the emergency room while I was working at the Veterans Hospital in Boston who told me he thought all of his food was poisoned and that there was a conspiracy of the government to, quote, get rid of him. This is an example of a persecutory delusion. Other delusions include thought broadcasting, mind control, mind reading, and thought insertion. These types of delusions are typically found in people who are developing schizophrenia or have a variant of schizophrenia. Thought broadcasting involves the delusion that one's thoughts are not one's own, Thought broadcasting involves the delusion that one's thoughts are being broadcast out loud so that they can be perceived by others. Thought insertion is the delusion that certain of one's thoughts are not their own, but they're inserted into one's mind from external sources. Similarly, mind control is a belief that something from outside the person, an external force, is controlling their thoughts or feelings, impulses, or actions. And finally, mind reading is that one believes others have the ability to read one's mind or that certain others can read their own mind. Last, we have grandiosity. Grandiose delusions are just what they sound like. These individuals tend to have an inflated sense of self-worth, power, knowledge, identity, or a special relationship to a deity or a famous person. This is typically culturally located. So, for example, depending on where someone resides geographically or their religious or spiritual beliefs, we may see variations. For example, when I was working in Boston, I found a lot of people with delusions that pertain to being connected to the Kennedy family. In other states, you might find other people being involved, and individuals may feel very connected to a religious figure like Jesus Christ or the Buddha. We can also see delusions of reference. This is an extreme version of ideas of reference I mentioned earlier in thought process. Delusions of reference are where events, objects, or another person in one's immediate environment has a particular and unusual significance. This, though, is usually negative or pejorative in nature, not grandiose, and it's held more firmly than ideas of reference. So, for example, when I was working on an inpatient unit, one woman on the inpatient unit said in response to seeing a school shooting on TV, "This is a sign from God." When the commentator was discussing the incident, this client saw it as God talking directly to her. She said, "He is calling me to be a disciple and to leave this place to promote peace and harmony." So delusions, again, are a false belief based on incorrect inference that are firmly held without change, despite evidence to the contrary. Finally, we have perception. We see disturbances in perception primarily through hallucinations. Hallucinations involve the sensory experience in the absence of a sensory stimulus. So it's a sensory perception that is compelling sense of reality, but occurs without any actual stimulation of the relevant organ. This is different from illusions in which there's an actual external stimulus, but it's misperceived or misinterpreted. We can see transient hallucinatory experiences that occur in individuals without a mental disorder. This can also occur in any sensory modality. Hallucinations can be auditory, involving perceptions of sound, usually experienced as hearing voices; visual, which involves sight and may consist of formed images such as people, or unformed images such as flashes of light, and should be distinguished from illusions during your assessment. Olfactory hallucinations involve the perception of odor, such as a burning rubber, sulfur, or decaying fish. Gustatory hallucinations involve taste, usually something unpleasant. And tactile hallucinations involve the perception of being touched or of something being under one's skin. The most common are sensations of electric shocks and sensation of something creeping or crawling on or under the skin like bugs. Now, one thing that's very important to determine is that with perceptual disturbances such as hallucinations, we cannot make the assumption that there's a thought disorder or a psychotic process happening. This is going to be more clear when we see disturbances in thought process and thought content, as I mentioned earlier. So hallucinations can come from various sources. Again, some hallucinations can be normal. We can also see hallucinations when individuals are using drugs, substances, or are withdrawing from alcohol, for example. Delirium tremens is a form of alcohol withdrawal where we commonly see hallucinations. We also can have hallucinations from medical conditions. So this harkens back to the important focus of always doing a physical exam before proceeding on with making a diagnosis of a mental disorder. So wrapping up, the mental status exam, again, involves numerous domains that we're going to assess. Some of these domains may be assessed in greater detail, and some of these domains may be omitted depending on the context in which you are doing assessment. For example, in an emergency room, an acute psychiatric ward, or an outpatient psychotherapy clinic. But overall, what clinicians are trying to do is to create a brief yet comprehensive assessment of mental status using terminology that is commonly used across professionals that can efficiently and effectively communicate the problems that our clients are experiencing. This is the end of this video and the two-part series on the mental status exam. I hope you found these remarks helpful as you understand the mental status exam and its relation to abnormal psychology.